Good morning, ma'am, and good morning, sir, and good morning to all of you. On my behalf, Dr. Saurav Singh, who has joined the Central Department of Hospital Administration, will take it forward. He'll give a brief background as to what did we aim at, and subsequent to that, Dr. Gaurav will deliver the presentation.
Good morning, one and all. Now, in this CGR, our department is presenting a study which was done through hospital infection control cell, which is in our department. And in this study was done in collaboration with our Department of Critical Care Medicine and Department of Microbiology. Now, this study was done in CCM ward. And in this study, was done to assess the compliance with the ventilator care bundle and its impact on the ventilator associated event rate and intensive care unit course of patients, those who are admitted in critical care medicine ward. Now, moving further, in today's healthcare landscape, patient safety and quality is at the forefront when we talk about giving quality of care in critical care setting. And one of the most challenging aspects is managing patients on mechanical ventilation in those critical care areas. We all know that the ventilators are life-saving devices, and they are very essential in managing critical cases, those who require ventilation. But they also are associated with risk, specifically developing ventilator-associated events. Now, when a patient develops ventilator-associated events, first thing which happens is that his duration of mechanical ventilation, it increases. Now, when that happens, automatically his duration of stay will increase, his out-of-pocket expenditure will increase, and there will be high risk, the mortality risk and the morbidity risk will also increase. Now, keeping that in mind, this study was conceived and conducted. Now, just to give you a brief about what we did in the study. Now, in this study, for data acquisition, we used two tools. One is the HI surveillance form, which is already available with us, and we have been using it. So in that form, we used component of VAE. And the second tool which we used was for bundle compliance checklist. Now we acquired data through that checklist, and we found out the compliance to all the bundles, all the components of the ventilator care bundle, and we also estimated the compliance rate. Now, once that was done, then the impact of the compliance was also assessed on VAE rate, then duration of mechanical ventilation, and also the duration of stay of that patient in the ICU. And also, we also analyzed the microbiological profile of the respiratory isolates from the study sample. Now, at the end of this, when we were analyzing the data of the study, we found out that, or we rather observed that the VA rate, length of stay of the patient, and the duration of mechanical ventilation, it reduced when there was compliance with care bundle was observed. So now, with this brief overview of the study which we have conducted, now I will hand over the proceedings to Dr. Gaurav Jha. He's senior resident in our department. He will present the study in detail. Dr. Gaurav Jha.
Good morning, one and all. Thank you, sir, for the brief introduction. The topic for the CGR today is a study to assess the compliance with the ventilator care bundle and its impact on ventilator associated event rate and ICU course of patients in critical care medicine ward. The hospital infection control team of hospital administration collaborated with the Department of Critical Care Medicine and the Department of Microbiology for the same. With September 17 being the World's Patient Safety Day, and in line with the theme for 2024, we are going to present this research. Invasive mechanical ventilation is an essential life-saving intervention for critically ill intensive ICU patients, especially in case of hypoxia, hypercapnia, and respiratory failure. Ventilator associated event is a major complication of invasive mechanical ventilation and is one of the most important device associated infection. The term VAE has replaced the older ventilator associated pneumonia, that is VAP, and is being used for surveillance purpose since 2013 by CDC, that is Center for Disease Control and Prevention, National Healthcare Safety Network, NHSN. The most important clinical consequences associated with prolonged invasive mechanical ventilation are increased antibiotic consumption, longer length of stay, significant morbidity, increased mortality, and increased healthcare cost. Care bundles are a set of evidence-based measures when implemented collectively and reliably have shown to result in better patient outcomes and have a greater impact than that of isolated implementation of individual measures. On reviewing the literature, it was found that most of the data from the developing countries, including India, report respiratory complication as ventilator-associated pneumonia and not in VAE, that is ventilator-associated event. There are several studies on risk factors and strategies to prevent VAE, but their applicability in Indian setting is still unknown. Only a few published reports from India are present on the impact of ventilator care bundle on critically ill, mechanically ventilated ICU patients. The aim of the study was to assess the compliance with the ventilator care bundle and its impact on the rate of ventilator-associated event and ICU course of patient in CCM ward. There were three main objectives. The first one, to estimate the compliance rate of the 6 components of ventilator care bundle in patients admitted in critical care medicine ward. Second, to evaluate the impact of bundle care approach on the VA rate, length of hospital stay, and duration of mechanical ventilation. Third, to analyze the microbiological profile of the respiratory isolates obtained from the patients. This is a prospective study which was conducted in 20-bedded mixed medical surgical CCM ward at our institute spanning for 10 months. All patients admitted in critical care medicine ward who were more than or equal to 18 years of age and were on mechanical ventilation for more than or equal to 4 days were included in the study. Patients intubated outside the hospital and patients with any contraindication to care bundle, like allergy to chlorhexidine, were excluded from the study. There were two tools that were applied in the study. First, a healthcare associated infection surveillance form developed by Department of Hospital Administration. Second, a customized ventilator care bundle checklist was used for data acquisition. There are a total of 6 components in ventilator care bundle, wherein the first component is patient position. Here we see elevation of the head end of the bed, that is by 30 to 45 degree. And this was assessed using nursing checklist or direct observation of the angle of bed, or in case of automated bed, monitor panel was to be checked. Gradient angle marking was also checked for manual beds. The second component is sedation vacation or assessment of sedation. Daily sedation interruption and assessment of readiness to extubate. This was assessed by direct observation during multidisciplinary round, documents review. Here you can see in the first image, there is an automatic bed, and in the monitor panel, it is 45 degree that is mentioned. So in this way, we reviewed the data was collected. And in the case of manual bed, the gradient angle was seen and observed. The third component was subglottic secretion drainage. Direct observation was done Documents were reviewed from the case file or the medical record. The fourth component, DVT prophylaxis, that is deep vein thrombosis prophylaxis. The direct observation was done if a sequential compression device pump was applied. Documents were reviewed from case file or the medical record in case of administration of heparin. In the first image, the procedure of subglottic secretion drainage is being shown. And in the second image, the observation that there are no secretions that was observed. In the first image where heparin is being used, as you can see, dalteparin medical record review was done. And in the second one, the SCD pump was observed. The fifth component, daily oral care with chlorhexidine. In this, this was assessed by direct observation and document review. Peptic ulcer disease prophylaxis, or also called stress ulcer prophylaxis. In this, we observed infusion pump or documents were reviewed for the same. As you can see, there is oral care with 0.5% of chlorhexidine, and here is the chlorhexidine solution that has been displayed. In peptic ulcer disease prophylaxis, observation was made on medical record, like Pantop is being displayed here, and infusion pump was also observed. This is a generalized HCI, healthcare associated infection form, applied at ICU, wherein our study focused on the VAE component. The VAE parameters that were included are the mechanical ventilation. Here we saw the mechanical ventilation is present or absent on daily basis. Then PEEP, that is positive end expiratory pressure. It was monitored on daily basis for clinical diagnosis, and fraction of inspired air, FiO2. Also, WBC count was seen, and for microbiological profiling, we saw use of new antibiotics. Patient must be mechanical ventilated for at least 4 calendar days to fulfill VAE criteria, where the day of intubation and the initiation of mechanical ventilation is on day 1. And this is the customized ventilator care bundle checklist that was prepared based on the CDC and IHI guidelines. It has 2 parts. The first part collects the basic demographic details like age, gender, and clinical baseline characteristics like Apache 2 score, SOFA score, and comorbidities. The second part to it included 6 components of ventilator care bundle, where data was collected in 3 shifts per day: morning, evening, and night. This is a duly filled customized ventilator care bundle checklist form, where you can see the compliance to the ventilator care bundle components was all or none indicator. Even if one component was missing, the case was considered to be a partial compliance with the bundle. With the calculation of few rates, ventilator care bundle compliance rate, that is total number of ICU patients on mechanical ventilation who received all 6 components of ventilator care bundle upon total number of ICU patients on mechanical ventilation into 100. The VAE rate that was calculated, VAE rate per 1000 ventilator days is total number of VAEs upon number of ventilator days into 1000. Microbiological profile of the respiratory isolates to ascertain the commonest pathogen and their sensitivity was also done. Statistical analysis, SPSS version 24 was used for data analysis. Descriptive data was summarized as numbers, percentage, means, median, interquartile range, and standard deviation. The slide is not come. Okay. There's some error that has come in the slide, but I'll just explain. This is a case screening and enrollment flowchart, wherein total number of admitted patient in the critical care medicine during the study period was 133. Out, out of which 41 patients were excluded, as 31 patients were intubated outside hospital and 10 cases were less than 18 years. Out of the remaining 92, 24 patients were not on more than or equal to 4 days of mechanical ventilation. So a total of 68 patients were included. Coming to the baseline characteristic of patient enrolled in the study that is summarized in the table, the mean age of the study participants on mechanical ventilation was 53.8 years, out of which 63% were males. Out of the 68 patients who required mechanical ventilation, 54 were admitted due to medical causes. The median Apache 2 and SOFA score for the patients on mechanical ventilation were 24 and 8 respectively. The most common comorbidity that was seen was renal disease, followed by chronic respiratory illness and hypertension. And a mean of 2 comorbidity was present in the study participants. The duration of mechanical ventilation ranged from 4 to 18 days with a median duration of 9 days. The median length of stay in ICU for patients on mechanical ventilation was 15. So there's some error where the graph is not being displayed. Yes, yes, sir. No, no, no. Yes, formatting. So this is a pie diagram where the compliance with the ventilator care bundle was shown, in which out of 68 participants, partial compliance was seen in 52 cases and full compliance was seen in 16 patients. So a total of 24 percentage wise, 24% was completely compliant with the ventilator care bundle in the study cohort. This is the overall ventilator care bundle compliance for each component that is shown graphically. There was a full compliance, like I explained in the previous slide, to all 6 components only in 16 patients. That is 24% of the subjects. Individual component, 94% of compliance was seen in head end of the bed elevation. 72% compliance was seen for DVT prophylaxis. 82% compliance was seen for subglottic secretion drainage. 98% compliance was seen for assessment of sedation, that is sedation vacation. 86% compliance was seen for oral care with chlorhexidine, and 99% compliance was seen for stress ulcer prophylaxis. But again, the bar is missing, the columns, and I'll explain. This figure represents monthly care bundle compliance among study cohort. It was observed that compliance with the following components of the care bundle improved from January. In the horizontal axis, you can see January. Basically, the total duration of the study was 10 months, but the data collection spanned for 5 months. So, as you can see in DVT prophylaxis, in January, it was 69, and a multidisciplinary team consisting of infection control nurse, principal investigator of the study, microbiologist, and resident of CCM, conducted various teaching and hands-on training for the nurses and the attendants of CCM to ensure full compliance to the bundle in the study period, and the results were tabulated. So as you can see, DVT prophylaxis, it was 69 in January, and later on, by continuous training, and it improved to 90% compliance. This I'm talking about individual components. Same way, in subglottic secretion drainage, it was 82 in the month of January, and it improved to 86% in the month of May. Oral care with chlorhexidine, it was 84 in January, and it improved to 92 in the month of May. Peptic ulcer disease prophylaxis improved from 99 to 100. And there are two components that didn't improve so much, but was above 90% because of the limitation of the study. One is head elevation, head end elevation, and second is sedation vacation. So this graph depicts the impact of ventilator care bundle compliance. The duration of mechanical ventilation, which was median of 12 days, reduced to 6 days when full compliance to the care bundle was followed. Also, the length of stay in ICU, which was median of 16 days in partial compliance, reduced to median of 11 days in full compliance with the care bundle. Coming to VAE rate, in this study, 9 cases of ventilator-associated event was reported during the study span in the study area. Total number of ventilator days were 969. Therefore, the VAE rate in the study was estimated to be 9.28 per 1,000 ventilator days. Coming to microbiological profile, out of the total respiratory samples sent for the culture, 88 were found to be culture positive. 74 tracheal aspirate, 10 bronchoalveolar lavage samples, 2 endotracheal aspirate samples, and 2 sputum samples were found to be positive. Out of the 88 positive culture, 79 were found to be gram negative. And among the gram negative, the majority were Acinetobacter baumannii, that was most common, around 47%, followed by Klebsiella pneumonia, that was 25%, and Pseudomonas aeruginosa, which was 23%. All gram-negative isolates were extended spectrum beta-lactamase producers, and majority were multi-drug resistant organisms. 33 out of 37 Acinetobacter baumannii and 95% of the Klebsiella pneumonia and more than 50% of the Pseudomonas aeruginosa were carbapenem resistant. Coming to discussion, the majority of the patients, that is 79.4%, admitted to study ICU were due to medical causes, and the median number of comorbidities among our patients on mechanical ventilation was found to be 2. Similar causes of ICU admission and comorbidities have been reported by Kumar et al. And Vunish et al. In Indian and US study respectively. Higher Apache 2 and SOFA scores in our study cohort could be due to the fact that our hospital is a tertiary care referral center, and therefore organ dysfunction was already present in majority of the cases at the time of admission. Subsequent to our intervention, the median duration of the mechanical ventilation and length of stay in our ICU decreased to 6 and 11 among patients with full bundle compliance. Similar positive ICU outcomes on the implementation of bundle care approach have been published by other authors as well. In a previous study conducted between January 2018 and June 2019, in the same study setting, that is CCM ward by Rupali et al., the VAE rate was found to be 11.3 per 1,000 ventilator days. To summarize, the study demonstrated that implementing and monitoring of ventilator care bundle is practical and effective in ICU setting. Successful implementation of care bundle during the study span led to the observation that there was quantifiable reduction in three parameters associated with mechanical ventilated patients in ICU study setting. The median duration of the mechanical ventilation, which was 12 days in case of partial compliance, was reduced to 6 days in case of full compliance, vis-a-vis adherence to the care bundle. The length of the stay in the CCM ward was 16 days in case of partial compliance and was reduced to 11 days in case of full compliance, vis-a-vis adherence to the care bundle. VA rate was reduced from 11.3 to 9.28 per thousand ventilator days. To conclude, findings align with the existing studies, confirming the effectiveness of care bundle in reducing VA rate, mechanical ventilation duration, and ICU stay. A systematic multidisciplinary team approach culminated in higher compliance vis-a-vis care bundle for critically ill mechanically ventilated patients. Adherence to the care bundle protocols and concurrent monitoring of the same proved to be essential in improvement in outcomes, highlighting its importance in critical care. The study encourages further research into the impact of care bundle on critically ill mechanically ventilated patients, particularly in different healthcare settings. The study confirmed that multi-drug resistant organisms are common in hospital setting and underscores the need for judicious infection control policy and a hospital antibiotic policy. To end, teamwork is the ability to work together toward a common vision, the ability to direct individual accomplishment towards organizational objectives. It is a fuel that allows professionals to attain uncommon results. By Andrew Carnegie. I would like to thank Afzal sir from Critical Care Medicine and Dr. Richa Mishra ma'am from my Department of Microbiology for this study. Thank you.